You're welcome to my channel. Today I'll be going through possible differential diagnosis of ST segment elevation. Here I have a small sketch of electrical activities starting with P, Q, R, S, then the T. But here should be the J point. Let me mark that. Okay, the J point should be here. And then this is the beginning of the T. So we are concerned about what is happening here. That is ST segment is right here. Now the ST segment. The KRS is representing ventricular depolarization. The T wave is pointing to ventricular repolarization. In between them is the ST segment. That is the region between the two above. The J point is the meeting point of ventricular depolarization and repolarization, like I've alluded to, and we will see in a bit again. Normally, the ST segment is isoelectric, meaning there's no voltage gradient at that level. If the ST is not isoelectric, then something is wrong with the myocardium. Okay, we've gone through the hand sketch, showing the different waves, but now I really want to get down to ST segment and point at elevation and depression. So this is the J point. Okay, you can see the J, right? Okay, and this is the beginning of the T, and this is the ST segment right there. You see that it is isoelectric, it's flat. That's what we expect under normal situation. Then the second diagram is then pointing to elevation of that. You see, this is the isoelectric point, but here there's a distance, it's elevated. So elevated ST segment. The third diagram is showing it more clearly. Okay, then if you now check down here, A, B, C, something different is happening here. You see that this is the isoelectric line, should be like this, but instead of elevation, it's down. You could see that it's down here, like this, okay? And then here, when you look at this again, it's also down, so it's down here, okay? It's down. And here, same thing is happening, it's down. So this is depression. This is depression. Unlike this that is elevated. See, if you go from here, is elevated. Okay, elevation from here like this, it's elevation. Okay. The differential diagnosis of the raise or ST elevation might be normal variance in young black men. So nothing, just like that. Or in my current fashion, I'll go into details in a bit. Left ventricular hypertrophy, right bundle branch block, left bundle branch block, acute pericarditis. The shape of ST segment might give a clue as to the diagnosis. When it is elevated and it is convex, that is pointing to ST elevation, myocardial infarction. But when it is elevated and concave, that is pointing to left ventricular hypertrophy that is not complicated. In early repolarization, it will be elevated more in lead 2 than lead 3. In inferior wall myocardial infarction, it will be elevated more in lead 3 than lead 2. However, depression of ST segment is possible, though it's pointing to trouble with the heart muscle, but in this case, it's not infarction. It is pointing to myocardial ischemia or certain medications or hypokalemia or secondary to exertion. In STEMI, it could be inferior wall myocardial infarction, and that would be lead 2, lead 3, and AVF. It could be septal, as V1 and V2, anterior, V2 to V5, anterolateral, V1 to V6, lead 1, and AVL. Still on myocardial infarction with ST elevation, could be lateral wall infarction, and that will appear through lead 1, AVL, V5, and V6. Could be anteroseptal, that would be V1 to V4, or posterior, V7, V8, and V9. It might be right ventricular infarction, and in that case, you're going to pick the elevation at V3R, V4R, V5R, and V6R. Other situations when we can find ST elevation, it will be pulmonary embolism, hypothermia, Brugada syndrome, raised intracranial pressure, Prince-Metal angina, now known as vasospastic angina, in hyperkalemia, in DZ transthoracic cardioversion, subarachnoid hemorrhage, stroke, left ventricular aneurysm, also in hiatal hernia, in acute pancreatitis, in myocarditis, in pneumothorax, in ventricular pace rhythms, in Lee's mispositioning, you can pick ST elevation. In atelectasis, in aortic dissection, medications like clozapine. In pulmonary metastasis, will also be elevated in Takotsubo cardiomyopathy, in acute cholecystitis, early repolarization. Remember, ST elevation with Q in the precordial leads 1 to 6, with or without 1 and AVL, is indicating high lateral leads. There will be reciprocal ST depression in the inferior leads 2, 3, and AVL. If we are then faced with inferior wall myocardial infarction or inferior wall with right ventricular myocardial infarction, then the patient might complain about diarrhea and we might pick hypotension and bradycardia. So the core of the treatment will include IV fluid and no nitrates, no nitroglycerin, no beta blockers. We have to keep an eye on the BP values, the heart rate, and of course the fluid level. And you do the rest now that you can do for any patient with heart attack. With that, I've come to the end of this short presentation. It is not all the time that the ST segment is elevated, that is heart attack. It might not be. So go through this list again, but rule out heart attack first. Thanks for listening. Remember to share this very presentation. Remember to subscribe to my channel. I appreciate that.